Right now, though, in this hour, we want to look at why the public health, or rather why public health is important and why we should finance it. And to help us have this conversation is Brown Ashira Olaly, who is the SG and CEO of Kenya Environmental Health and Public Health Practitioners Union, KEHPHPU. Tulikuanga naye hapa some time back. Brown, karibu tena sana to Radio Generation.
Happy New Year. Thank you so much.
Happy New Year to you too.
Radio Generation, and thank you so much for having me once again.
Yes.
I salute you.
Karibu sana.
Thank you for embracing public health.
Asante
This discussion
sana.
is very healthy and good.
It is actually a very important and healthy one.
Very healthy.
Siti akona methali alitupatia asubuhi.
Yes.
Ningependa akupe alafu utupe maoni yako kuhusu hiyo methali. Siti, over to you.
Our proverbs for this week are from the Republic of Cape Verde.
Cape Verde.
It's like a group of islands in archipelago. Kule
West
in the Atlantic.
In the Atlantic.
You know, yes, this continent is interesting because we have the Atlantic.
Yes, on one side.
And then we have Indian Ocean.
On one side.
We're surrounded by two oceans.
Yeah, and we also have the Mediterranean, pale juu.
Sasa, we actually can't be compared with anybody else.
Yes. Okay. And if we take it further, by the way, down south we have the Southern Ocean.
Yes.
So we are surrounded by four water bodies.
Yes. Interesting, isn't it?
It is
very interesting.
Yes. Now, this is one of those countries where the people in the diaspora are more than the citizens in the country. It has that unique characteristic.
It's very unique, yeah.
Yes, watu wao wengi wako nje.
Yes.
In the US, wengine wako Portugal, wengine
the organic people are not in that country. Most of them are in the diaspora.
Imagine.
They're actually in the diaspora.
Very interesting, yeah.
They are. It is, but nonetheless, you should see the picture of that country. If I were asked where I'd like to go, I'd like to visit that country. Okay? We have an archipelago, tunaita Lamu.
Yes.
Lamu is not one island. No. Kuna Manda, kuna Pate, kuna Siu. All those things. Yes. All those form that particular, what you call an archipelago.
That is true.
The proverb, okay? If the baboon could see his behind, he'd laugh also.
Okay.
Yes.
Okay.
What do you think this proverb means?
Okay. Yeah, it means everybody has got his own dark, the dark area or the dark place. So ideally then all of us, no human being is complete.
Yes.
Including me and you. There's a way we have been made special, so we need to focus.
Yeah.
You don't look at your dark areas. You need to focus. There's a reason why it was put behind.
Yes.
The reason is simple. Is because you are supposed to focus. The dark areas they are not important.
Yeah.
The good areas lies in front, and therefore we need to focus in front.
Yeah.
So the baboon, like Sitia said, it has this dark place. The behinds are dark and are actually behind.
Yes.
And the in front looks beautiful. So
focus.
You focus.
Focus on the future.
Focus on the future.
What you can control.
Control the future.
Asante.
Look ahead.
You've actually put it in a different perspective. Mimi na Siti hapa asubuhi tulicheka vitu zetu. But I like how you've put it.
Yes, thank you so much. By the way, I heard you say, somebody was saying UDO was stage managed. Personally, I was in State House yesterday.
Okay.
And I don't think it was stage managed. It was an aspirants forum.
Yes, it was.
Where people were actually being invited to discuss about, the ideas of this country, the good politics and the ideas of this country.
Yes.
I think where we are going, it might not be, where we are, it might not be the best place, but we also need to focus where we are going. Yeah. Actually, where we are going is more important than where we are. So I had an opportunity to interact with the president yesterday, and the discussion was good. I'm a Kenyan, and I would want to participate.
You're a Kenyan and a politician.
Not really a politician. Politician is not really important.
The moment, allow me to explain.
Yes, sir.
The moment you are part of a union,
yes,
you're a politician. You cannot be a unionist.
I like calling myself a leader, not a politician, because politicians are like politricks. You know, it's like they don't direct people, but leaders give good directions and good guidance.
Correct.
Yes.
Right. Okay.
Yeah. Thank you.
Yeah. No, but the viewer actually didn't say it was stage managed. He was actually saying it was a good display. This is what he said. Amesema, hello colleagues, you have to hand it to them that UDA show was perfectly staged, not stage managed. And then he goes on to say everything from the layout to the performances was designed to impress. It was a massive show of force, plain and simple.
Correct.
Yes.
Correct.
By the way, we've been discussing it this week.
It was a nice thing.
Consider, for instance, this is something other parties should consider. They opened a portal.
Yes.
And anybody who wished to vie on a UDA ticket for all electoral positions was asked to,
come in.
State your name.
Yes.
If you're a party member, state the details of your party membership.
Yes.
State the position you wish to vie for and pay the 2,000, 3,000 or 5,000 you're supposed to pay.
10,000 of governors.
That is it. Okay?
Yes.
It was oversubscribed by 650%. Okay?
Yes.
It's a portal.
Yes.
So it raises a question. This is what we discussed yesterday. We said, you cannot now say that this is a party that is not popular.
Yes. That is
You
true.
could if you want to, but the numbers will tell you otherwise. That's number one. We also said, we now understand why gambling works. Because please, Paul 29 numbers.
Yeah. Thank you.
Well, wacha tuingie katika gumzo lililotuleta hapa. And it's on public health.
Yes.
You're a public health official. Officer, right?
Yes.
For someone who's probably asking themselves, wait, public health tofauti na any other kind of health ni gani?
Curative.
Yes.
I'll say this. Public health, it entails, it's a whole discipline. We call it preventative medicine. We deal with the prevention of diseases, protecting lives and prolonging, protecting the population and prolonging lives.
Yes.
Essentially, we derive our definition from the WHO, that's the World Health Organization definition of the word health, where it means that it's a state of complete physical, mental, and psychological well-being, and not just merely an absence of a disease or infirmity. So we go beyond. We actually stretch beyond diseases. We actually, our work as PHOs is to make sure that we protect the population actually from falling sick. And I want to say this: our strong nations and strong communities are built on public health. If you go to the Singapores, if you go to the Canadas, if you go to the USAs of this world, they invest more in public health interventions so that we don't need necessarily to have a projection of a sick country. We need to have a projection of a healthy nation. People who are actually very productive because people who are sick, they're never productive. When people are sick, we have a lot of school absenteeism. We have a lot of less productivity. People don't perform to the optimally to what is expected.
Yes.
And Benjamin Franklin once said that an ounce once invested in public health is worth a pound of cure. And that is very true, because if you compare, if you are to invest right in this country and put more resources in public health, it essentially means that we're actually not going to overwhelm our hospitals, because look at the level of our hospital. Actually overwhelmed. Most people are going to the hospitals. We are experiencing a lot of upsurge. Actually 70% of the infection actually reported in our healthcare facilities are actually preventable. They are actually communicable.
Yes.
They're actually, this is actually caused by bacteria, the fungi, the lack of clean water, the lack of poor sanitation. A lot of issues, and there are things which public health officers do on day-to-day basis. Our work is actually to mitigate and ensure that we control those hazards and ensure that our community is actually very safe.
Yes.
There are no cases of malaria, the infection of malaria. And you saw what happened the other day with a lot of, there's a reported case of an upsurge of new infection of HIV.
Yes.
And among the teens. And that is a thing that's actually attributed to public health. Most people are not using condoms, for example.
Right.
We actually practicing unsafe sex practices. Our eating habits are actually not up to standards, and therefore we are actually contracting a lot of HIV. We are actually contracting a lot of hypertension, so diabetes is actually on the rise. Cancer cases. You saw what happened. Oluga was the PS Oluga yesterday at Kenyatta National Hospital. Patients were literally crying. Why is with the cancer issues? The cancer wards are full. I mean, you cannot have a country that we actually experience a lot of cancer issues. And cancer is caused by simple things: disposal and unsafe disposal of maybe of nuclear waste. You saw what is happening in is it Northeastern, where we saw Meru. A lot of cancer cases being reported in Meru because of unsafe disposal of nuclear, waste. Nuclear waste is being actually dumped, and it percolates. When it is dumped, when it rains, it percolates into the soil, and people take that water, full of contaminants.
So the nuclear waste is being dumped in the Meru area.
Yes, in Isiolo. If you go in Garissa,
inatoka wapi hiyo nuclear waste?
It was being, we have manufacturers, a lot of people in those areas who actually don't know even how to dispose waste. And that is actually an issue that we really need to have a discussion about so that we can be able to ensure that we control, we have an interesting way how we can be able, people need to be educated on how we can be able to control waste and dispose it the way it's supposed to be done.
Okay.
Yeah, so it's a public health is all about the population. We look at an individual, our perspective to an individual is different from a doctor. When I look at you, my brother, Royal City, the way I look at you is not the same way the doctor will look at you. We take care of the population. Doctors take care of individuals. When they fall sick, we take care of the larger population to ensure that actually they live healthy and they live well.
Yeah, what you're saying basically is that you're the first line of defense.
Exactly.
Before we get to the hospital.
And we are actually the first line of defense, and we believe households should be the first line, because at level 1 we are the first line of defense, and when we control diseases from that point, I can tell you for free, even level 6 will not have patients.
Do we have a structure that can enable the public health sector to actually fulfill their mandate effectively?
We do.
What is that structure? Describe it for us.
We, at the Ministry of Health, and I want to say this, I want to thank the government and also they came up with a national, right now we have a National Public Health Institute, the one that actually supposed to take care of emergencies and the one that is being led by Dr. Kamene, which we have also raised pertinent issues as public health officers. Yes. If you look at the management of that institute, from the ministry to the institute, it does not, 70% of those functions are supposed to be public health oriented. But if you look at them, they're actually being manned by doctors. They're actually being manned by our colleagues who are actually done clinical care. And we actually raised those pertinent issues. And we are yet to see the CS do that. But back to the question of the city, we have actually a structure at the ministry. And this structure is drawn from the Health Act, is drawn from the ministry, where we have from the ministry we begin with the CS, then the PS. Under the PS for Public Health and Professional Standards, that is my Honorable Mary Mudhoni. We have now the Director General. Then we have now the State Department of Public Health and Professional Standards. Under the State Department of Public Health and Professional Standards, we have a a whole directorate of public health and sanitation being led by Dr. Muleshe, the current director for public health and sanitation. And then under the directorate of public health and sanitation, we have a division of environmental health being led by the Honorable Mutie. And it goes down to the counties. Remember, health was also devolved, but the Ministry of Health plays a significant role in terms of policy direction, because counties are there to domesticate and maybe implement the policies at the Ministry of Health. Then from the Ministry of Health, we have divisions. Then now the counties, where we have each and every county has got its own structure based on the County Government Act. Remember, the County Government Act gives the mandate to the governors to be able to set out their governments the way they will want. The areas you find public health, for example, in other counties, we have a Directorate of Environmental Health, we have a Directorate of Public Health, others are calling it the Directorate of other things. But the whole idea, according to our scheme of service and the scope of work, is we believe that there should be a Directorate of Public Health being led by a public health officer, who is duly registered by the Public Health Officers and Technicians Council. Remember, we have a council that regulates public health practice in this country. And therefore, we believe that they should be able to follow that scope, be able to follow the scheme, and ensure that we have that structure working. And the reason why we have been having issues of financing is because we don't have a structure that is working. We have it in papers, but the guys managing the structure, they are non-PHOs.
But that structure that you just described,
yes,
doesn't encourage one into believing that what you seek to achieve will be achieved, because it is top heavy. You see, for public health to work, from the way I understand it, you need to have a structure that one can understand cascades to the village level. So, cascade this structure that you have mentioned to the village level. We hear of public health promoters. I understand their role. But how do you ensure that these particular officers who are assigned 100 households, what is it that they do that guarantees that the public understand simple things like sanitation? They understand,
water.
And that there's a unit where people are trained to help mothers manage the newborns.
Correct.
That they help manage the infestation of things like malaria. Disposal of just basic waste. Things in the community which, if not attended to, become a healthy breeding ground for the ailments that then cause the problems.
That's correct.
And brings a bottleneck to the health service. This structure that you've mentioned, how does it cascade to the lowest possible level?
Thank you so much. First of all, I want to say this. There's something I want to correct here. Community health promoters are not public health officers. Community health promoters, we essentially used to call them community health volunteers. Actually, it is this government that actually given them that new name tag, the community health promoters. And we work with them. We used to supervise them. If you look at the Kenya Expanded Health program, we used to have CHIUs at the community. The CHIUs were comprised of the public health officers, the nurses, and the nutritionists. And then we have the CHVs now there. And I want to thank the government because we have actually incentivized the CHPs. We have given them, equipped them, given them the necessary what is supposed to be done, and then now they're actually working closely with the public health officers. But to say the least, we feel that even the 5,000, the 2,500 that is being donated by the national government, the 2,500 being donated by the county, is not adequate enough to be able to morale boost these officers. They need to be given permanent and pensionable terms so that they can be able to effectively discharge their mandate. We have over 107 CHPs.
What do they do?
The CHPs is the first line. They link. They link the community or the household to the healthcare facility. The CHU, we call it the community health units, which will have the CHPs, the PHOs, and the CHAS. We call them the community health assistants, who work internally, because one CHP is supposed to take around, within a CHU, supposed to around 100 households. And they actually work together at that household and the village level. From the household level, we have the CHU. Then from the CHU, they link. They're supposed to report. There are elements, CT, that actually happen. People don't know it's important to sleep under a mosquito net, for example, to get not to be exposed to getting malaria, for example. There are people who are the TB defaulters. There are people who are sick. They actually have the TB. They move around, distributing TBs to people. Those are people they need to be quarantined and put in a place that to ensure that, and be educated and ensure that taking drugs, for example, is important.
This cadre of worker, CHP, CHU, CHA, are any of these trained in public health?
Actually, we gave birth to CHS. We call it community health strategy. If you look at in the year 2007, it's actually public health officers. Community health is part of what we do. It's actually a singular unit of what we do in class. And most of the guys, even the CHAS who do public health, are actually public health officers.
They're trained.
They're trained.
Where are they trained?
In Kenya medical training colleges, we have the universities that are actually training public health officers. Go to Kenyatta, go to University of Nairobi, go to JKU.
Okay.
All of them.
Those
they have some skills.
They
Yes.
have a lot of skills. But the community health practitioners that we are speaking of,
Yes.
these people are trained to be a link, not to provide healthcare services. They are data collectors essentially.
Correct.
Okay? Is there curriculum for training them?
We do not have a curriculum for training CHPs, and I want to contextualize this. And that's why, as a union, we're actually sitting down. We want to sit down with the ministry. You know, every cadre in the health sector, and healthcare provider in this country need to be regulated. We need to know who is providing health to who. Remember, we have had a lot of quacks. People masquerading and going around saying, we are healthcare providers who can do this. And we have actually made a proposal to the CS and also made a proposal to the PS that we need to ensure that we review the Public Health Officers and Technicians Act number 12 of 2013 and bring this kind of cadres, like for example, the health promotion, the community health, and the population health, so that they are regulated. You know, I want to give an example. Kenya, the doctors.
Yes.
Doctors have a council called Kenya Medical Practitioners and Dentists Council. This council regulates doctors, it regulates medical officers, it regulates pharmacists. Recently, they actually
licenses.
It licenses and COHO. But if you look at the preventive space, we have a fragmentation of people who are actually not regulated. And that's actually a very serious issue, and it actually poses a great danger to the population. We need to ensure that we review the Public Health Officers and Technicians Act to ensure that it regulates within the PHOTC Act. We have it regulating PHOs, the public health officers in Kenya. We have it regulate the community health officers in Kenya. We have it regulate the CHPs. We have it regulate all these cadres who are actually providing preventive service in this country. You know, we cannot have people moving around without regulation. I know PHOs are regulated, but then we need to ensure that we collapse that silo thinking. You know, there are people who think that they cannot be regulated.
The regulation bit, I am in full agreement with you. However, why I ask about the curriculum is this. When HIV popped its head or rears its head, we weren't prepared for it. We did not know what to really do with it.
It is true.
Because it was new. It's just like COVID. We didn't know what to do with it. But HIV gave us a window of opportunity of understanding the very thing you're saying and how public health becomes important.
Important, yes.
Okay? Because HIV and the proliferation of it was more social than it was medical. To get people to understand why it is they needed to adhere to certain norms, whether it was the preventative norms by using protection or using pre-exposure prophylaxis, or everything around it, you needed to get people's minds to move from how they had previously responded to the subject and the activity of sex to understanding what they now must do if they hoped to be alive and well.
That's correct.
So it produced cadres of people who previously had not existed. The people who worked in that field were forced to innovate.
Yes.
Okay? And that's where the term of task shifting became very paramount. We understood that when people were unwell, they came to a clinic.
Yes, it's true.
It then became clear that you perhaps need to go to them. Because some of them may not come. Care-seeking behavior indices showed clearly that if you are asking someone to juggle the resources they have between attending, coming to hospital and feeding their children, they'll feed their children.
It is true.
They'll wait until they are almost dead to be able to come to the hospital.
Yes.
So what am I saying? With an increase in population, public health becomes the most centralized and the one subject area that we must focus on if we're talking about extending the process of healthcare to the people who need it most. Okay?
The unreached,
We don't need to reinvent the wheel.
That's correct.
I work in HIV/AIDS research, care and treatment.
Yes.
We had a cadre called CHA.
Yes.
CHHA.
Yes.
These are people we had to write a curriculum for.
Fourth.
Because they didn't practice any healthcare. But what they did, they were part of the people who were the peer educators. They were the people who educated people when they came into the clinic about. They are the ones who helped, because the vast majority of them were also HIV positive.
That's correct.
Okay? So they were peer educating something that they lived with.
Yes, yes.
Small little activities like simply counting the drugs as directed and knowing that this is what you need to do. The task shifting became a problem because the question of training came in.
Yes.
Were they trained in any registered training institution?
Yes.
And we asked the question, do I need to be trained to count? I am counting drugs. I'm already trained, that's why I can count. I am not dispensing. What I'm doing is, you have a patient whom it is not me who documented it. There's somebody who handles that. This person comes after every 2 weeks, okay? This is what you do. You take the vitals. I don't need
the vitals. Yeah.
Getting someone's height and weight. Do I need medical training to do that? No, I do not. But what you do,
why?
You relieve.
Why do you think you don't need medical training to do that?
Because the person.
But then, do you know what is medical training?
No. Medical training.
We need to begin from there.
Yes.
Because you're actually offering. That's a healthcare service you are doing.
I am trying to explain. It is a basic healthcare service that does not require intense training.
But at least training. It requires training.
You brought the argument that gets to the heart of the matter. That's the bottleneck in providing healthcare services. The training that a healthcare provider gets has very many other things that a layperson cannot possibly do.
And that is what.
So, one of the headaches we have in health provision is that we have inadequate staff.
That's correct.
So do you want this person who is a public health practitioner trained, or a nurse trained, or a clinical officer trained, to be engaged in this? Or do you want somebody who can actually do that little bit while they do something which this person cannot do because they don't have the training? That's the task shifting. What do you do?
Fragmentation is a problem. We already have a cadre. We have public health. And this problem is sometimes created by the government itself. When we fail to embrace public health, and then we try and fragment what already exists, and that's a problem we're actually trying to create. We need to reorient health, just to begin from there. First of all, we need to understand what each and every person does in the ministry. The ministry is made up of different cadres. We have the cohorts, we have the PHOs, we have the pharmaceutical technologists, we have the nurses, we have the clinical officers. Each and every cadre has got a specific scope, and we are regulated specifically to do a specific mandate that we actually train in school to do.
In reality, does that work when you are in a health setting? In reality, are you telling me somebody falls sick and there's a nurse? Are they going to wait for the public health practitioner to come in? Are they going to wait for the clinical officer to come in? Or are they going to attend to the patient? What
essentially, it's supposed to be working. Essentially, it's supposed to be working that way.
Which health facility has enough trained personnel to enforce this regulated system that you're talking of? Which one? Where?
I can tell you confidently none. We don't have none in this. And that's why we've been on record as a union trying to pressure the government to employ more power. In fact, when the president came in, and I'm a very good student of history, the president said, and we participated. I was at the Catholic University when we were actually invited as healthcare union leaders to draft a manifesto of the president. And we actually agreed in principle that we're actually going to employ around 20,000 healthcare providers in different categories. That promise by the president has been negated. I mean, we are having 100,000 teachers being employed, and we don't see the importance of employing at least 20,000 healthcare professionals in this country. And that's a problem. And the way CT has rightfully put, population keeps increasing. For example, right now, if you go to Pumwani Maternity Hospital or whichever health facility, most people are being, watoto wanazaliwa. We're actually giving birth. And the population actually is growing. It's increasing. But we're actually putting a lot of pressure to healthcare workforce in this country. But we don't employ, we don't train, we do not actually, for lack of a better term, try to skill boost, You know, there's that skill boosting. Even the guys who have been trained who are the system. If you ask me when they were last taken for refresher courses, I think I can tell you for free. It's been a while.
Maybe
because there's a problem. We don't finance. You know, we don't put in place mechanism to ensure that these gentlemen, ladies and gentlemen, who are actually offering healthcare service in this country, they're actually refreshed by actually going for refresher courses.
I want to go back to that point where you said you met the president when he was campaigning, right?
Yes.
When you met him, what were the proposals that you gave him, and what did he agree to?
We actually asked, because the healthcare, the HRH component, you know, for health to work, we have actually 5 pillars. We have the healthcare financing, we have the HRH, we have the digital technology, and all products and whatever to be done, medicine and what have you.
Yes.
There's a component that we actually asked him. Actually, you can build hospitals, my brother, but you can build so many, like when NMS did in Nairobi. But when you build hospital, buy medical equipment and have all this, but you don't have the healthcare workforce.
Yes.
Actually, it becomes actually useless. Because the component of HRH, those are the things we actually advise the president to do.
Okay.
Employ enough healthcare providers in this country. Employ enough public health officers to take care of the diseases.
Did you give him a number?
Yes, we did.
Which number is this?
That's what we're talking about. Like, for example,
20,000.
The 20,000. And we agreed the 20,000 are going to be spread across the different cadres. The doctors, we had a specific number of the doctors. The nurses, we had a specific number of the nurses. The PHOs, we had a specific number of the PHOs.
Okay.
And also the clinical officers and other cadres. But it is a situation, and you saw, that's why we've been seeing perennial strikes, because we agree on this, but we don't actually implement, and that has been actually our greatest problem. Recently, you saw the clinical officers going for actually a 36-day strike.
Yes.
That actually culminated to them signing a CBA.
Yeah.
We don't need to go on a strike, my brother, to better healthcare services in this country. If we have the right cadres and you have the right financing in place, we have parliament and we have all those guys, the PSS working, with all the systems actually working, we'll be able to see that, for example, and I can tell you for free, by 2028, we might actually not have enough PHOs at the headquarters, at the Ministry of Health. Currently, the public health officers whom we have at the Ministry of Health, actually the aging population, they're actually over 40, 45, 50 and above. So those guys actually going to retire. We're actually going to have an empty shell, a vacuum of public health officers at the Ministry of Health, which is not good.
PHOs have not been hired for how long now?
Since 2012. We are actually not hired. The ministry has not hired. And we're asking the PS Modoni. You know, we have been having discussions. By the way, let me tell you, we are on an open union. We believe in negotiations. We don't believe in going to strikes. We believe in having our issues done at the table. But when we have an honest discussion, that's where now you'll be able to find the union is now going on strikes.
The last time a PHO
was employed
was in
2011. Actually, before even the new constitution.
Yes. So now, this entire time, all these people that have been graduating from the universities with public health degrees,
PHOs, and the environmental health officers and the PHO have been graduated, they're actually outside here. Some of them have resorted into doing other very funny things. And you know that
that's 15 years. You know, I'm still there.
Yes.
So for 15 years.
Get your data with the ministry. I dare tell anyone, ask the ministry to challenge me. You know,
so where
I
these
also have data as a union. I'm the SG and the CEO of the union.
Yes.
I have raw data on when they were last employed. And what I'm saying, a statement of fact, the ministry need to come out and clearly, disapprove me wrong.
Right.
Because we are looking at the healthcare, and public health is a preventive service recognized in the constitution of this country. When you're not employing, what you are saying, what you are doing is this, you are denying the Kenyan population a preventive service that they rightfully are supposed to be having. You get the point.
Yesterday when you were at State House, did you have this conversation with the president?
Yes, I actually raised it, and actually we actually raised the president, and we actually asked the president to have an appointment with us, because we have actually looked on our way to engage the CS. The CS for health is actually avoiding us.
This is Aden Duale.
I'm telling you, Aden Duale, I can't
when you say avoiding us, Brown, when you say avoid,
and I'm not happy. By the way, we are not happy as a union.
He's not taking your calls. He's not
engaging us. is actually seeing us as not very important.
Have you gone to Afia House?
Yes, we have been having meetings. I mean, we are called for a meeting. For example, the PS.
Yes.
For example, we agreed we are meeting.
This
today.
is PS Modoni now.
Modoni, yes.
Okay.
We meet today. We come and meet with the PS. He comes in, technically moves away. He leaves us with junior officers at the ministry who cannot make decisions. I mean, you cannot. You know, decisions at the ministry require people who can make decisions.
Yeah.
And the PS is a principal accounting officer.
Yes.
Of the ministry.
Actually, she said it herself.
Yes.
Tulikuwa na yeye last week.
Yes.
Mbona ukunipigia simu ni muulize tu
Ungeniita
live.
akiwa amekaa hapa, by the respect PS Modoni.
And
we support her. And in fact, for the State Department of Public Health to come in place, we went, I can tell you for free, I was among the guys who went at gate B. We delivered a petition to the president at State House, and we asked the president, can we have a State Department of Public Health and Professional Standards to manage public health services in this country?
So, courtesy of you, this
State
Department was created.
We made a petition. We didn't want this State Department to be, infiltrated by doctors. Doctors have their State Department of Medical Services being led by the Honorable P.S. Oluga. This State Department was supposed to handle emergencies, was supposed to handle public health issues, was supposed to handle preventive medicine. It was supposed to be percolated again by guys in the medical, the clinical era. But we're having a situation, we have a ministry, we have a State Department of Public Health and Professional Standards, now being infiltrated by doctors. I have absolutely no problem with my colleagues as a doctor. But I have a problem with the management. Let me tell you, City, it pains to the core. Because it pains to the core because... No, it pains to the core.
Do you know actually see where he's coming from? Do you know where he's coming from?
It's a frustration, I'm telling you for free.
When you have people whose mandate, primary and only mandate is preventative.
Yes.
And then it is people whose mandate is curative.
Yes.
You have a problem. He is right in raising his voice. He is right in raising the issue. Because if indeed public health was being prioritized by that State Department, there are very many issues that we keep discussing here which would not be issues.
Which should not be issues, actually.
Because
actually, when our PS, and I really respect our PS Modoni, actually she was ranked the second best performing CS after PS after PS, the interior PS for the interior PS Omolo. And the reason was simple, is because we have Epuka Uchafu campaigns that actually it is doing well. But again, you cannot have a State Department being run by medical doctors. No, we will not say.
What if
the best thing City to do is speak truth to power?
Brown.
Yes.
What if the medical doctors are epidemiologists?
No, they are scope. You know, there's a training. If you go to a medical school, for example, let me use myself as an example. I'm a public health practitioner by training.
Yes.
There's a curriculum for me. There's my orientation of my training. My orientation is actually purely prevention from the basics. And I like what you said, from the basics to masters or to PhD.
It is preventative.
It's preventative. But when I do my basic, for example, in medicine, Bachelor of Medicine, then I go now to epidemiology. That's a specialization.
That's
a specialization.
The doctor is focused on the curative aspects of healthcare.
It's simple.
All right.
That is the position.
You and yourself. But let me ask the question. Do you think that simple, ordinary citizens who can actually be trained to assess, to diagnose, and even treat certain illnesses, do you think that is possible? Mwananchi tu hajaenda medical training school, hajakuwa that whole 3-4 years hajafanya. Can you train a local in a village setting, a mwananchi, to assess, to diagnose, and to treat certain, not all illnesses, certain?
I'm taking note of the word trained. Train in which area?
You see,
when you talk about training, we need to be very careful. Sometimes when we talk about training, the issues of curriculums come in. The issues of what? Unless we're talking about maybe, I don't know, for a better.
Actually, I'm going into it because there's the integrated community case management process.
Yes.
You've heard of it.
I've heard of it.
Okay.
Yes.
And it was, I know because I was part of the piloting of it in Homa Bay County, so I understand how it works. All right. Now, the focus was purely on one, basic childhood illnesses like pneumonia, diarrhea, malaria, and malnutrition. Bas. nothing more.
Nothing more.
Basic.
Correct.
Okay? Essentially, everything you did was syndromic. See, unangalia, kuna hii. Okay?
Yes, yeah.
Now, why do I mention this every time I have an opportunity to talk about this? Is because it was a 3-year program, and the outcome, this project was led by a certain lady who is called Dr. Marciana Onono. Dr. Marciana is the deputy director at KEMRI. Yes. This 3-year process, what it taught, or the outcomes that it showed, was that this process actually prevented attendance at health facilities by 75%.
Thank you.
Meaning,
the outcomes were good.
All the outcomes were very
good.
That's
Excellent.
why it is spoken of, and that is why.
Yes.
And by the way,
you are correct.
Yes.
And by the way, let me tell you, and that's what we are discussing. In fact, you're on point. That's what we are actually discussing here.
Yes.
If we invested at level 1, at that household level, and we trained, these guys we call CHPs.
Yeah, boss.
They are good people. And that's why there's a reason why we work with them closely, with the public health officers. The reason is simple. Why? We train them on basic things. You get it? Then we also we just don't train them. We work closely with them and supervise.
You oversee what
they do. So that they also don't go overboard in what they actually do.
Wasijifanye madaktari.
They wasijifanye madaktari wa kijiji. They should know that these are our limitations and this is where we are supposed to actually be able to reach. And even having said like that, and I like what Setia said, 70% or 75% of those illnesses can be prevented if we rightfully invest from the level 1.
Yes.
If we put the right personnel, if we put the right PHOs, if we equipped them, if we employed enough personnel and gave them the necessary tools to be able to work at the level 1, I'm telling you the truth, you not see pressure at the healthcare facilities.
No.
Doctors, in fact, in developed countries, let me surprise you a bit. In developed countries, hospitals are being turned into training centers for lack of people. Why? Because they have invested in public health. They have invested in preventive.
People are not falling sick.
People are not falling sick, in short, because people have been. People know. For example, I can't do smoking. For example, if I smoke, I get, for example, lung cancer.
Yes.
For example, if I don't exercise, for example, I can get diabetes. I'll put on unhealthy weight. I'm at a risk of hypertension, for example. So people are sensitized. The communities understand. Well, for example, when I am pregnant, I need to sleep under a treated mosquito net so that I don't contract, for example, malaria. And issues to do with sanitation, so on and so forth. So that's what we are saying. And I like the dream of the president. We need to be the Singapore of this world. But you can't go to Singapore with unbalanced financing, with a country that is skewed towards curative. We need to go to Singapore with a balanced nation. Yes, we agree people can fall sick because of, there are levels of prevention also, the primary, secondary, tertiary, and all those levels. Yes, we agree people can fall sick. But then before we even reach at that level, can we try and protect and prevent even the risk factors of the people? Let's try and educate the people on what needs to be done so that they can stay healthy. We can have a healthy country. We can have a productive country. And so we really need to do that. And let's avoid, sometimes I look at the ministry, we have the best policies, by the way. But again, if you look at the guys implementing, unapata pale kwa ministry, it's like kuna watu wamekamatiwa chini. You get it. People know what they need to do, but they're not doing it. But some, there are cartels at the ministry. If I try doing this, nitafukuzwa kazi. I keep telling people at one point, even what I'm doing right now, I'm not going to be the first and the last person to do it. Bwana City.
Yes.
I'll do it today, and what matters is do the right thing. I want to challenge the ministry, particularly our PS, Mudhoni.
Yes.
Embrace public health officers. We are the best. We can control 100 the diseases we're actually experiencing right now. And I want to request you, make sure and invite him with the PS. Even the CS will be able to cascade, have data here, raw data, to tell the PS and even to advise the CS on what need to be done. But again, if they avoid us, they think that we are not important. You'll keep seeing chikungunya coming. You keep seeing anthrax. The other day you were seeing people Marburg, mpox, COVID-19. A lot of emerging and re-emerging infections which can actually be prevented. But when we embrace this teamwork, we give to curative what's actually supposed to be curative and give to prevent what's supposed to be preventive, it becomes good. Let me surprise you as I maybe make a point. Going by the last budget,
yes,
it will impress you, or it will surprise you what we got.
Yeah,
there was a whooping 132 billion, but we only got a paltry 18 billion, and even that 18 billion that we got in our previous budget, in fact, it was even short-changed. It didn't do actually the public health issues.
What did it do?
It did other things. You know, we have people, very funny guys at the ministry, who masquerade as PHOs. They hold programs like school health, for example. They hold programs which are not actually theirs. There are doctors who are gynecologists. There are doctors who are good in other things, who are actually doing things which are not supposed to be.
They're not public health practitioners.
They're not. But they have been given programs which are actually not theirs. So we're asking reliably and humbly.
Yes.
Because we are not shopping at it city. These are not empty threats. We are willing even to go to the judicial courts in this land and even sanction the highest court in the land to compel the government to embrace public health intervention in this country. We cannot have a country that is projecting us to be falling sick anytime. The only thing you can see the CS saying, let's get sick. You know, I mean, we can't do that. We need to see a country that's wholesome, that's actually embracing preventive as well as curative. You know, that should be the way to.
You know, Brown, I am in full agreement with you, because even in terms of cost effectiveness,
yes,
the preventative aspect of healthcare is what a country like ours ought to embrace. Yes. Because we actually prevent that process which eventually takes people to hospital to require cure. That provision of requiring cure is costly. It is extremely costly.
Yeah.
But it seems to be preferred by doctors.
It's not even like that. I think the systems in this country are the ones actually working.
Systems are run by people, Brown.
Yeah, but
they are run by people.
Those systems, they seem not to think that public health is important.
The reason why I'm focusing and I'm pointing at doctors is for a simple reason. The healthcare services in this country are run by doctors.
Which is wrong.
My point exactly. My point. And I'm saying that very many doctors understand this discussion we're having, and they understand, and they themselves support, promote, and propagate the need for us to focus on the preventative aspect of healthcare. They understand it, and they do so. However, there are people in decision-making positions who, for reasons that perhaps are of benefit to them directly, prefer the curative aspect.
Can I tell you something?
Yes.
Do you know, we had a huge discussion on the Health Act before it was implemented. There was a very huge discussion on the Health Act. The Health Act was actually, even the Director General, if you look at the qualifications of the Director General for Health, it was actually preserved for someone who has done medicine and surgery. We had a discussion back at, even went to court and even challenged that. And the court actually stood with us and said in the ruling that to be a Director General for Health, for example, the position that Dr. Moth holds, you don't need necessarily to be a medical doctor. You just need to be a healthcare trained personnel in a respective field regulated by a specific council. Because we actually even envisioned actually what we are saying, because when you have specific people at the decision-making table, and that's what we are saying. And you know, initially we didn't have a union as public health officers in this country. We are saying, let us balance these things. The court stood with us. But even with the court ruling, the ministry still think that the doctors should run the show. We are saying we have no problem with the doctors, but let them give to Caesar what belongs to Caesar and give to God what belongs to God. Do not try and think that you are the only one man holding the show and running the show and twisting the coin at the same time. So what we are saying is just simple. You know, since we were registered as a union, let me surprise you. We were registered in the year 2022. we have met all the requisite qualification warranting our recognition.
Yes.
We have been making application to the Minister of Health to be recognized. The Minister of Health has negated to recognize us.
Yeah.
You ask them why. We have actually presented all the requisite, including the membership. All our members have joined our union. What they're asking is simple: recognize us. Recognition does not attract monetary aspects.
But what does
they have failed to recognize us.
Yeah, what does the recognition look like?
I mean,
what happens when you're recognized?
You know, when you're recognized, when you sign a recognition agreement,
you sign a recognition
agreement with the ministry.
What does it mean?
Now you are now sit on the table of decision making. It means now you can now sit together if there are decisions, for example, of this nature or regarding prevention. You can now be invited and discuss. But they don't want to recognize us. We make application. We have made all the qualifications. They do not want to recognize us. And somebody wonders us why. Have we not gone to school? Are we not offering preventive service in this country? Somebody thinks somewhere and thinks that we are not important. And that's what we are saying. They should think twice. You cannot have a country that envisages people to fall sick. I mean, we need to have a healthy nation. And I want to ask the president. We were in State House yesterday, and we were not giving up on this call. By as public health officers, we need a meeting with the president,
right,
so that we can be able to iron bit by bit of these issues.
Did he give you an appointment yesterday?
Yeah, he said he's actually gave a direction to the State House controller to give us an appointment. So we're actually looking into it. And if he doesn't do that, we still go back to State House and still ask for that.
But I mean, going directly to the president means you're saying the minister has failed you.
Yes, because we have been, actually, I can even show you. Letters have written to the ministry here. Several calls to the CS. Several calls. In fact, even my WhatsApp message, I write a message. He looks at it.
And a blue tick.
A blue ticks. And then the areas
this is now CS Duale.
Yes,
he blue ticks you.
Yes, he blue ticks. He does. I think he doesn't know. I mean, we've written several ones.
Paul, what is blue ticking again?
That means that your message has been read and ignored.
Oh, that's blue ticking.
Yes.
Goodness.
Yeah, that is what essentially it means. He blue ticks us. The PS reads it, she responds.
Okay.
At some points, she gives us an appointment. She comes in technically. She leaves us with the people who cannot make a decision. It leaves us there stranded.
But Brown, let me ask.
But the issues...
If she leaves you with her officers, is it not that the officers will then take the deliberations to her later?
Can I surprise you?
Surprise me.
She left. At one point, she left us with the current director for public health and sanitation.
Yes.
And even had a discussion. She actually advised and gave a directive that can you look at these issues bit by bit, panel beat them, let me have an answer. When we actually did everything, we actually handed the report to the whoever that actually left us, and we actually requested, can we take it back to the PS? We're hoping that she's actually going to invite us, agree on what we have agreed, or maybe the areas that require that we sit down and maybe
panel beat a little bit.
We actually wait up to now. That discussion we had last year. Up to now, I've been following that appointment. It has not been forthcoming.
Okay.
So ask me what could be the reason.
Okay. Now, Brown, we've come to the end of the show.
Oh my goodness.
Yes.
Inakuwaga hivyo hapa.
1 hour yetu imeisha. But clearly I have registered your frustration personally, and I think I understand where you're coming from, and some of the things you've said obviously very critical. Public health officers are at the forefront of ensuring that we can fight these diseases before they get to a point whereby now we are calling them national disasters. Umesema chikungunya, tusipojipanga hizi vitu zitaanza kurudi. I wish you all the best as far as reaching the CS is concerned and the ministry as a whole and even the president. Na ikishindikana kuja tu tuambie kuliendaje.
No, nitakuja, and please organize, and thank you by the radio generation for amplifying this. This discussion is very healthy. By the way, I want to request humbly that let's have more of this discussion, because it is that person at the tail end who's supposed to be benefiting.
Yes.
We're not doing this because of ourselves.
Right.
We want all the Kenyans, because public health is our right in the Constitution, Article 43. Let them be able to benefit, because that is what essentially it means.
Right.
But as a union, as public health union, Honorable CS, we are ready. We are willing to engage. We remain open. Honorable PS, we remain open. We want to have this discussion in the boardrooms. We don't believe in going to strikes to have our issues handled.
All right. Thank you so much.
Thank you.
Here we come to a stop as far as this conversation is concerned.